When we discuss cardiomyopathy, we know there are three types. Basically, there are three types. Okay, one is dilated, hypertrophic, restrictive. So, first of all, before you start knowing about cardiomyopathy, you must know the basic difference. Okay, so when you say dilated, you remember this thing that when you say dilated cardiomyopathy, so D for drugs. It's just a tip to remember: drugs or alcohol. Dilated cardiomyopathy very commonly caused by drugs or alcohol. So you can remember these things so that it will make you easy to understand the difference. Hypertrophic, remember one thing, one catchy word is sudden cardiac death. When there is hypertrophic, there is sudden cardiac death. Very common. Okay. And restrictive, you remember, R for mostly it's right-sided heart symptoms. Right-sided symptoms. Okay. Right-sided symptoms. Remember that. These three things are the basic things that you need to understand. Okay. Now we go with dilated cardiomyopathy first. So what is dilated cardiomyopathy? So we know that in dilated cardiomyopathy the heart enlarges. Okay. So let's say this is the ventricle. This is the normal ventricle, and in dilated cardiomyopathy, this normal ventricle will be enlarged. It will be roomy. You see, it's so much room, space. Okay, now it is hypertrophy, then how it is dilated? So first of all, remember, it is basically caused by drugs like cocaine users or alcohol abuse or viral infections like Coxsackie virus, enterovirus, HIV, hepatitis. So to have dilated cardiomyopathy, first thing we need is the myocardial insult, what we call as myocardial insult. Myocardial insult means injury to the myocardium. Okay, so let's say these are the myocardial cells. These are the myocardial cells, myocytes. So what happens whenever there is any strict alcohol abuse, like proper ethanol toxicity? So when a person is drinking around 6 drinks every day for 5 years, okay, for 30 ml a drink, 6 drinks every day for 5 years, then it can cause cardiomyopathy. Okay. Now question comes, which cardiomyopathy is caused by alcohol abuse? Remember, this is dilated cardiomyopathy, not hypertrophic or restrictive. So what happens when there is alcohol abuse or some viral infections or some cocaine users? What happens? There is damage of this myocyte. So as a result, these myocytes are damaged. Okay. The healthy myocytes are damaged. So what will happen? The portion where the myocardial cells are damaged, it will be very, very thin. So now there is thinning. So because of the thinning, it has got stretch. So because of the thinning, this has got stretch. So there is stretching of the ventricular wall. Stretching of the ventricular wall. Now this part is destroyed by the virus or by alcohol or by cocaine users. Destruction of the myocytes. So let's say because of this hepatitis virus or HIV viral insult, these myocytes are damaged, right? So when these myocytes are damaged, what will happen to this portion of the ventricular wall? It will be thinned. So when it will be thinned, it will stretch more, right? Now, but this is a cardiomyopathy. Okay, so is it only stretching? No. When there is stretching here, there will be compensatory hypertrophy. There will be compensatory hypertrophy. But this goes very slow. This is progressive. So we say when there is dilated cardiomyopathy, what we say? We say there is stretching. As a result, there is dilatation, and then progressive hypertrophy. It's not that there is no hypertrophy, there is progressive hypertrophy. So there is progressive hypertrophy. Means the whole ventricular chambers, they become roomy, they become very, very big. And remember, in dilated cardiomyopathy, the heart becomes very heavy, at least 2 to 3 times of normal of size, heavy, and it is stretched, so it's flabby, and it is hypocontracting. Hypo, which means basically it is a systolic failure. Basically, this one is a systolic failure. Systolic failure. Systolic failure. The ejection fraction goes very, very down. The ejection fraction, it goes very, very less than 35%. Normally it's 50 to 55%. Okay, so ejection fraction goes very, very down in case of dilated cardiomyopathy. That is one thing. And remember what I told you. Dilated is systolic dysfunction. Systolic dysfunction. And one more thing to remember in dilated cardiomyopathy, remember there is no narrowing of coronary arteries. Okay, in many websites you'll find different things, but I'm telling you from the books from Harrison and Robbins, there is no narrowing. Myocardial vessels which are inside, okay, let's say this is the myocardial vessels, this is the myocardium which is stretched, so there is myocardial vessels, these are not narrowed, so there is actually less chances of developing angina or some cardiac pain or something like MI like symptoms. Okay, less chances. Now what happens again? This is systolic dysfunction, means it's flabby and more blood is coming up, so diastolic volume is increasing. Okay, more diastolic volume and diastolic volume is increasing, so the ventricle is enlarged. Now it is failing to contract. So there is a systolic failure. It is failing to contract. Okay. Now when the blood is becoming stagnant here, what may be the complication here? Because more blood is collecting here, less blood is ejecting out. So what is happening? There is always a chance of thromboemboli, because there is a formation of thrombus when the blood is stagnant. So thromboemboli is common in dilated cardiomyopathy. Okay. So what are the causes? If you go quickly, what are the causes? We know there can be viral causes, Coxsackie virus, enterovirus, hepatitis virus, HIV virus. Then it can be also like sarcoidosis. And it is also asking MCQs, which cardiomyopathy is found in pregnancies? Peripartum cardiomyopathy. Okay. Now we don't have any particular reason why there is dilated cardiomyopathy in pregnancy. Just remember that in pregnancy there is volume overload. There is so all the metabolic things are rearranged. Metabolic rearrangement, not dearranged. Okay, it's a pregnancy. It's a normal physiological thing. There is metabolic rearrangement, and because of that, there is multiple factors. Because of that, there is some myocytes may be damaged, and as a result, there is dilated cardiomyopathy. So one more questions, MCQs: which cardiomyopathy is present in alcoholism? Dilated. Which cardiomyopathy is present in pregnancies? Dilated cardiomyopathy. Okay. So viral, sarcoidosis, peripartum. We know drugs like cocaine users, alcoholism, and what else? And also some drugs like doxorubicin and hemochromatosis, sarcoidosis. And don't forget, there is also doxorubicin, hemochromatosis, and also there is a chances of genetic background. Genetic influence may be there, familial. Multiple members of the families are involved, then sometimes it can also run in families, but not as strong like hypertrophic. Okay, but there is some genetic background here. So what are the points to remember with dilated cardiomyopathy? It is a systolic dysfunction. Okay, so it is a systolic dysfunction. This is a systolic dysfunction. There is dilatation leading to progressive hypertrophy. There is thromboemboli. Okay, and what else? And remember, there is basically In none of the other cardiomyopathy, ejection fraction is decreased. Here there is ejection fraction is quite decreased, less than 35%. Normally it's around 50 to 55%. Okay, we know ejection fraction, how much blood is ejected. Okay, so it goes down below 35%. Okay, so in dilated cardiomyopathy. Right. Now we go to the next, hypertrophic cardiomyopathy. So in hypertrophic cardiomyopathy, remember, when you say hypertrophic cardiomyopathy, so when there is cardiomyopathy without any background of hypertension, when the cardiomyopathy is not due to hypertension, okay, so when there is no evidence of hypertension, hypertensive cardiomyopathy, no evidence of valvular disease, and there is cardiomyopathy, then you say it's hypertrophic. Hypertrophic. Now there is typical hypertrophy of the cardiac myocytes, means of the left ventricle, especially of the left ventricles. So let's say this is the interventricular septum, and this is left ventricle, this is right ventricle. So there is hypertrophy, typical hypertrophy. And remember, this is asymmetric hypertrophy. Asymmetric hypertrophy. More hypertrophy towards is the interventricular septum. In the interventricular septum, means this part is more thickened. Now if you draw the proper left ventricle, how it will look like? The left ventricle is, okay, it looks like this. So this is, here there is aortic, this is the aorta. Okay, it goes like this. Okay, so here there is the mitral valve. So this is the aorta. Aorta goes like this from the right side. Now in the hypertrophic cardiomyopathy, we say interventricular septum is more hypertrophic. So interventricular septum is more hypertrophic. Okay, so interventricular septum. So you see the cavity, the ventricular room is quite down. It's decreased. Normal space is decreased, and here it becomes banana shaped. There is anatomical obliteration of the left ventricle. It becomes banana shaped. Banana shaped. And sometimes when this interventricular septum is so much hypertrophic, then it can also lead, when there is systolic, it can lead to obstruction in the ejection, obstruction in the systole, because it's hypertrophic, and aorta just goes from here, goes from this side. So when there is hypertrophy, it can obstruct this flow, obstruct the aortic valve, right? So what happens here? In 10 to 25 cases of hypertrophic cardiomyopathy, there can be obstruction during systole. So that's why in earlier days it is also called as hypertrophic obstructive cardiomyopathy. Though nowadays we only use hypertrophic cardiomyopathy. So what will happen? So when there is a interventricular septum is so much hypertrophied, right? So there is, so first thing you remember is that this is a diastolic disorder, okay? Diastolic disorder. So because of the obliteration of the space, because the space is reduced, so less blood is collected in the end diastolic volume. So diastolic disorder. So less filling of the ventricle. So when there is less filling of the ventricle, that is not a problem, but the problem arises when this person is doing some exercise or playing some sports. So when you have a heavy exercise or playing any sort of sports, then our heart has to contract more to supply more blood. The stroke volume must be increased at that time. So because of that sports or heavy exercise or some sort of exaggeration, what will happen? More blood is needed. So, but there is already less filling. So it is unable to supply more blood. As a result, it can cause sudden cardiac death. Okay. So this is one of the most common cause of sudden cardiac arrest or cardiac death in athletes. And it runs in family. There is a strong genetic background here where there is a mutation of, okay, it is also asking for a mutation of, you see, arginine to glutamine, GLN, glutamine, okay, or leucine to valine. There is strong mutation here. There is a strong evidence of genetic background. It mostly runs in the families. Okay, when the father has a sudden cardiac arrest, his son or someone else in his family, so they may also have a sudden cardiac, because it has a mutation of evidence of mutation in the family, in this genetic code, arginine to glutamine or leucine to valine. Okay, so what happens now? This interventricular septum is hypertrophied. Okay, but the problem arises, as I discussed, problem arises when he has to go for a heavy exercise or go for a sports. When there is a heavy demand, then they are unable to supply, and as a result there can be sudden cardiac death during sports. This cardiac death don't arise when he is in a resting position. It arises when he is in a treadmill or some sports or having some exaggerations or stress kind of thing. Okay, so this thing is hypertrophic cardiomyopathy. You remember in what I discussed, hypertrophic cardiomyopathy is a diastolic disorder and it will lead to sudden cardiac death. Now when we will do ECG, what will you see? You see in ECG, this is also asked in MCQs, you see the prominent Q wave or septal Q wave. Prominent Q wave in ECG. Now how does... Okay, let me explain it to you. Okay, where when you do ECG, you know P, okay, P, Q, R, S, T. We know these things. Now what? This is Q wave. Now when this Q wave is produced, okay, we know the QRS is because of ventricular depolarization. Okay, so when this Q wave is produced, normally what happens? There is left to right depolarization. Left to right depolarization means this part is activated and it is going through the interventricular septum, and right, it is activating the right side also. Now in cardiomyopathy, when the interventricular septum is hypertrophied, okay, and this part is also hypertrophied, so there this cardiac impulse is not actually depolarizing this part, it's just going quickly over this. So normally this Q wave we don't see in red. That's why this Q wave we don't see it in leads V1, V2 and V3. We don't see Q waves. Okay. Normally we don't see the Q wave in V1, V2 because they are right-sided lead. Okay. In comparison to V4, V5, 6, they are more towards left and it's more towards midline. So there we call them as right-sided leads. Normally in V1, V2, V3 we don't see Q wave. But if you see Q wave in V1, V2, V3, that's a pathological Q wave which is found in MI. Okay, so because of early depolarization, this Q wave will be deep. It can go very, very deep. So normally it is got only one small square. We know this is in ECG there is 5 small squares makes one big square, which is one small square is 0.04 second. We know that. So normally this Q wave is 0.04 second dip. Is 0.04 second dip. But if you see this Q wave is more than 2 small squares dip, or more than 2 small square width. Okay. Now normally this is 1 small square. If it is more than 2 small square width, more than 2 small square width, or you see the Q wave in V1, V2, V3, or more than 2 small square dip, or more than 2 small square width, then we can say this is a pathological Q wave. Okay, so in hypertrophic cardiomyopathy, in electrocardiogram, you will see pathological or septal Q wave. Means you will see Q wave in V1, V2, V3 leads also. You will see the Q wave is very deep, more than 1 small square. Okay, more than 2 small square, and the width is, okay, width means how much boxes is calculated. It should be 1 small square. It is more than 2 small square. Okay, and then we can diagnose that this is a hypertrophic cardiomyopathy. Okay, but it is very, very, remember, hypertrophic cardiomyopathy is that cardiomyopathy that has no hypertensive background. that has no valvular defects. But it is very, very indistinguishable from hypertrophic cardiomyopathy. That is also one thing. And what happens here in hypertrophic cardiomyopathy, there is, as I discussed in dilated cardiomyopathy, there is no narrowing of myocardial vessels. Here there will be narrowing. The myocardial vessels that are inside, it can be narrowed because of the hypertrophy. Okay, they can be narrowed. So as a result, in hypertrophic cardiomyopathy, there is history of angina. There is history of angina. There is history of angina or chest pain. Now we know that hypertrophic cardiomyopathy is a diastolic dysfunction. Means less blood is coming into the left ventricle because left ventricular space is reduced. So less blood is coming from where? Coming from the lungs. So if less blood is coming from the lungs, so in the lungs, the blood volume is increasing. So there is progressive pulmonary hypertension. So there is congestion of blood in the lungs because less blood is coming from the lungs. So in the pulmonary veins there is less blood, more blood is collecting. So as a result, there will be shortness of breath. Shortness of breath. Okay, this is also one thing. So in hypertrophic cardiomyopathy, what is the difference between dilated? Hypertrophic cardiomyopathy also heart becomes very heavy. It enlarges, but it is hypercontracting. Hypercontracting, not hypocontracting. It is hypercontracting heart. It's heavy, more than 2 to 3 times of normal size, large, and it is hypercontracting. And it is a diastolic disorder. And it can cause myocardial vessels narrowed and produce angina-like symptoms. So it's very difficult to sometimes distinguish between pericarditis and hypertensive heart disease. Okay. And what else? Yes, there is a familial background here. Very strong evidence of familial background. Thromboembolic chances are here also. And you see now this, because of this less diastolic filling, is not able to give enough blood to our organs. Right? So there can be all exaggerated anemic-like symptoms, dizziness, hypoxic-like symptoms. It can also, whenever there is any sort of exertion. And what else? There is thromboemboli. Yes, it can be done. It can be also present. And in both the hypertrophic and dilated, there is always a chance of mitral regurgitation. Mitral regurgitation. And fourth heart sound can be heard in both the types, dilated and hypertrophic. Fourth heart sound, mitral regurgitation. Now, why there is mitral regurgitation? You see, where is the mitral valve? So this is the left ventricle, and this is left atrium, and this is the mitral valve here. Okay, mitral valve is here. So when it is become stretched in dilated cardiomyopathy, this valve cannot close properly. Or when there is obstruction here because of hypertrophic ventricular valve, this mitral valve cannot close. So there is always chances that when there is a leakage of the blood, means from atrium to ventricle, there is chances of regurgitation. So mitral valve regurgitation is very, very common in your hypertrophic cardiomyopathy. So what can be the complication if there is hypertrophic cardiomyopathy? Arrhythmia is very common. What are the complications? Let's see. So if there is so there can be arrhythmia. There can be arrhythmia. There can be thromboemboli formation, thromboemboli, arrhythmia, then infective endocarditis. There can be sudden death that we already discussed. Why there is sudden death? I already told you that when there is increased demand, there is failure to supply because of obstruction by the bulging interventricular septum, which is obstructing the aorta. Okay, and as a result, there is obstructive cardiomyopathy. That's why in the earlier days it was also mentioned as hypertrophic obstructive cardiomyopathy. Now let's go to the third one. What is restrictive? Restrictive. As you remember, R for right side. right side. So this is the left ventricular wall, left ventricular. Okay. Now there is proper infiltration. There is proper infiltration. This infiltration, so there is some foreign substance inserting into the ventriculum, into the myocardium, and it is making this myocardial wall restrictive, stiff. Okay. So what are the things? It can be iron, that is in hemochromatosis, but very commonly amyloids, amyloidosis, sarcoidosis. Okay, and any sort of glycogen storage disorders, Some drugs can also do, like serotonin. So in restrictive, the myocardial wall, it becomes, the ventricular walls and the myocytes, they become properly stiff because of some foreign substances infiltrating. So it is an infiltrative disorders. So as a result, it becomes stiff. So to have diastole, it needs to relax. So it's failed to relax, means this is also a diastolic disorder. And it more prominently affects right ventricle. Okay, more commonly it affects right ventricle. So there's right-sided heart failure, right-sided heart symptoms, or when there's a right ventricle suffers, what will happen? There can be some JBP signs, like prominent Y descent. Okay, Y descent prominent in JBP. There can be abdominal pain. Okay, there can be abdominal pain, right side abdominal pain. There can be ascites. So all these right-sided heart signs will be present in restrictive cardiomyopathy. It will be present in restrictive cardiomyopathy. Okay, so that's what we need to remember. That in restrictive is mainly right-sided. Fourth heart sound can find, and you can find some JBP signs. All right-sided abdominal pain, ascites can be present. Okay, swelling of legs can be present. Okay, and this is also a diastolic disorder. And one thing to remember, sometimes it is asked in USMLE also, that why there is digoxin toxicity. So when there is a restrictive cardiomyopathy, the digoxin should be very carefully used, because what happens when we give digoxin to a patient with restrictive cardiomyopathy caused by amyloidosis, then this digoxin can be trapped. So this digoxin that we are giving, it can be trapped here between the amyloid fibrils. So as a result, it can cause toxicity. So this is one thing. So this is about restrictive cardiomyopathy, and these are the cause. Other causes, other less common causes are carcinoid syndromes, tumors, radiations. So anything that infiltrates. Okay. So this is the basic difference in cardiomyopathy. So hypertrophic, then hypertrophic obstructive, you can say also, restrictive cardiomyopathy, dilated cardiomyopathy. So this is about cardiomyopathy.